I stopped at hemodialysis the last time. Just wanted to have you go and read it, but I figured it makes so much sense to quickly go over them. So today I'm going to start with kidney transplant, kidney transplantation, and we continue from there. So I'm going to share my screen. Okay. Can we see the screen, kidney transplant?
Yeah, I'm looking.
So if you have questions, just stop me and ask. We have kidney transplant. It's a human kidney from a compatible donor and is implanted into a recipient. So you take a kidney from somebody and it has to be somebody you are compatible with. It's just like blood transfusion. So the patient must take immunosuppressive medications for the transplant. So if you get a kidney transplant, you get immunosuppressive medications for life. I have those medications under the medication list. We'll discuss them. So you have to take the kidney transplant medications for life. Now we have the donor. The donors may be living donors. So it can be somebody who is alive or somebody who is dead. So if you are a man and you have a girlfriend who is younger than you and you have a kidney failure and your girlfriend decides to donate her kidney to you, it has to be somebody who has 2 functioning kidneys and you have to be compatible with the person, and then they donate the kidney to you. So the donors, we also have another form of donors who are the dead people. That's why they keep asking people to donate body organs. You sign that if you die, they can donate your body parts to the, they can donate your body parts to, I think we have the people that take them, we have the eye people. So mostly it is encouraged by all hospitals that anybody who dies, if you are taking care of a patient who died, you have to immediately call to report the death so that the donor people, the people that receive those body organs, they can come in and assess the patient and they pick up the organs. So if you sign that you want your body organs to be donated, they will donate the body organs. So if your family say, don't do it, and you had signed, then they're not gonna go with what your family is saying. If you are living and you opted that I want to donate my eyes when I die, if you die, you are there taking your eyes. If your family say no, don't do it, it will be too late for them because you have ordered it whilst we're still alive. So those orders overrule healthcare proxy and whoever is going to be your next of kin, because you did it out of your will. So they wouldn't stop that. Now let's talk about graft rejection. We have hyperacute rejection and chronic rejection. We have acute rejection as well. So we have 3 types of kidney rejection. We have hyperacute, we have rejection, and we have chronic rejection. So hyperacute is 8 hours after transplantation. So immediately the patient get the kidney transplant done, then within 48 hours, that's is that 3 days or 2 days?
2 days.
2 days. Yeah, that's within 2 days. So within 2 days, you start having symptoms of rejection. That's hyperacute. Then we have the interventions for that is to remove it because you just had it transplanted in you. So the intervention is to go back and take that kidney out. Then we have the acute rejection, and this one occurs within a week post-operatively. So after they have done the operation to put the new kidney, it takes from 1 week, and it can occur anytime after transplantation. It can occur 2 months, 3 months, 5 months, 1 year. Now, The intervention is potentially reversible with increased immunosuppressive therapy. So because that one does take time, they give you the immunosuppressive medication to see how it works. But basically, if it's something that will just not work, they will have to still take out the kidney. But mostly they try to manage you with immunosuppressive medications for life. Chronic rejection, that one is slowly, and it's from months to years after transplantation. So you can get a transplant today, and 5 years later, you start having the symptoms of kidney rejection. So the intervention is immunosuppressive medications and dialysis if necessary. So if in like 3-4 years, your kidney have started failing again, they put you on immunosuppressive medications and they put you back to dialysis. So that's it about the types of the transplant. And except in an identical twin donors and recipients, the main postoperative complication following kidney transplant is graft rejection. Graft rejection. I forgot the percentage of rejection, but it's like we have a higher percentage of kidney transplant rejections in the system. So now the clinical signs of renal transplant rejection. What will you see if a patient comes to you and the patient problem is rejection of the kidney transplant that they had 2 weeks ago? So the symptoms that you will see will be that there will be fever. The patient will be febrile, a temperature above 100, and pain or tenderness over the grafted kidney. So if the patient had the right kidney transplanted or the right side fixed, then the patient will point pain to that side. Then 2 to 3 pounds weight gain in 24 hours. So you know that gaining 2 to 3 pounds in 24 hours, that means your kidneys are not doing any excretory function. That's a sign of kidney loss or a sign of kidney issue. So you have fluid buildup in your body and you gain weight. So if you gain weight, you have edema and you have hypertension, you have high blood pressure, malaise, you have elevated BUN, elevated serum creatinine levels. We had talked about the lab test that is done for renal patients. I did go over that video. I see that it's like not most of you went over that video. So try and check the diagnostic test that is done for patients with kidney. So you have decreased creatinine clearance. So creatinine will not be cleared enough. That's why you have the high serum levels of creatinine in your urine. And we have rejection indicated by ultrasound or biopsy. So when they do an ultrasound or they do a kidney biopsy, they will see that. And we will also have elevated white blood cells, elevated WBCs. Now let's look at cystitis, urinary tract infection. Anybody have a question about kidney transplant so far? Okay, so let's look at cystitis. I'm trying to go over this as much fast as I can because I really didn't want to go over that, but it's okay. We have cystitis, urinary tract infection is the same. That's inflammation of the urinary bladder from an infection, obstruction of the urethra, or other irritants. So urinary tract infection is inflammation of the urinary bladder from an infection, obstruction of the urethra, or other irritants. The most common causative organism is Escherichia coli. So take note of this organism. I know someone who went for the exam and told me they had a question. They were asking to know what is the most common bacteria that you will suspect when a patient has a UTI. I'm not saying it came directly like that. I don't know how the question was framed, but the person did tell me that from the way the person framed the question, they wanted to know if the person has understanding of what organism is usually a suspect when it comes to UTI. So Escherichia coli and Enterobacter, Pseudomonas, serratia species. Cystitis is common in women because women have a shorter urethra than men. And the urethra in women is located close to the rectum. close to the rectum. We know that the rectum allow for a lot of junk to come out of it. So if the urethra is closer to it, we all know where a woman's urethra opening is, where it opens to for you to urinate, is more into the vagina. So all the mess in there, it does get more infection. So women are prone to UTI than men. Sexually active and pregnant women are most vulnerable to urinary tract infection as well. So we have the assessment findings. What do you expect to see if a patient comes to you and complain? What are the common complaints you will expect? Or what will you assess? Or what will the patient tell you for you to know that this is UTI? The patient will complain of frequency and urgency. I go to bathroom so often these days, and anytime I have to pee, I cannot hold it. I have to run to the bathroom. That's urgency. Burning on urination. When I urinate, I feel like I have some burning down there. Voiding in small amounts. Then they tell you, I try to pee. When I pee, I still feel like I still have urine, but I just cannot release everything out. Then others will complain of their inability to void. They'll tell you, I'm not able to urinate. I know I have to urinate, but I'm not able to urinate. Incomplete emptying of the bladder, that you understand. Lower abdominal discomfort or back pain, bladder spasms, cloudy, dark, foul-smelling urine, hematuria. So some of these symptoms, you just need to have the patient go and pee. And when you look at the urine, if it's dark, cloudy, and it's smelling, you can smell the urine. You see blood in the urine, that you will know. But when it comes to burning or urination, patient has to report to you. That's why we have subjective and objective data collection. So the patient will tell you how I feel. So you collect that information. So the moment a patient presents to you telling you that I have lower back pain, and anytime I go to the bathroom these days, I urinate a lot, and I feel itching or burning sensation, sometimes they don't know how to describe it. So the moment a patient explains that to you, you start assessing them of urinary. So sometimes a patient will just say lower back pain, and I also feel a little cramps down there, down in my stomach. Then you ask them, do you have urinary symptoms? So it's part of assessment questions you should follow up to ask. So the patient can have fever, chills, and malaise. The white blood cell count will be elevated on urinalysis. So it will be higher, to be greater than normal. Altered mental status is a sign of UTI in older people. So you are the nurse on the floor, the patient, the EMS guy brought the patient from a nursing home, and they tell you the patient started hitting everybody this morning. The patient wake up and was confused, went to the bathroom and cannot go back to her room. And this is a patient who has been alert and oriented, fully alert and oriented, walking around doing her stuff. And the patient cannot remember which her room is. The patient is so confused. So take note, altered mental status. Anytime a patient is presented to you with altered mental status on the exam, the next thing you want to find out is, did they put an age limit? So if it's an older person, they tell you the patient age is 68, the patient is 74, the patient is 85. Then don't think Alzheimer's first thing. Don't think dementia first thing, because it's not all older people who have those things. But you want to ask, does the patient have urinary symptoms? So patients who are older, old age, they have a problem with UTI. So older people are prone to urinary tract infection, and they will present with frequency, urgency, and may not be specific symptoms of UTI because of urinary elimination changes that occur with changes. So this with aging. So because of aging factors, they may not be able to give you the specific complaint, but they will tell you the patient is been confused all day. Now, the interventions for a patient with a UTI. So before you administer any medication to a patient who complain of lower back pain, burning, or urination, you want to get the urine first. You want to run it and make sure that you have seen it, you have diagnosed it. So you suspect, strongly suspecting that this is UTI. after you have gotten the urinalysis result. The other day, I showed you people how a urinalysis result will appear. Some are negative. We have the proteins, the ketones, the urine gravity. We have the WBCs, the serum creatinine, and all those things. So you will see all of that. So if you see them altered from the normal, then you can confirm the diagnosis that is actually UTI. But before you start giving patient any medication, you want to get urine specimen for urine culture and sensitivity, and then to identify the particular bacterial growth. So you encourage the client to increase fluid. So remember, in the beginning of this lecture, I had told you that a patient that presents with urinary problem, mostly, especially when it comes to the urinary tract diseases, mostly you want to encourage fluid to help with elimination. But where there is fluid accumulation, you don't want to give. Like in the case of kidney failure, kidney rejection, hemodialysis, they normally advise fluid restriction. But for patients with urinary infectious diseases, you want to encourage hydration to flush out all this bacteria. So take note of that. So fluid, a patient with UTI, you encourage them to drink a lot of water. A patient with kidney stone, you encourage them to drink a lot of water. A patient with gallbladder issues, you are encouraging fluid. But when it comes to those that causes edema, then you don't encourage fluid. You have to try to go with fluid restriction. So at least 3,000, that's 3 liters a day. At least 3 liters a day. So if the NCLEX present you with a question and they say the patient has been diagnosed with UTI and the patient present to you, the next thing you want to check is also dehydration. So you have to hydrate the patient to help flush out the kidneys. And especially if the client is taking sulfonamide. Sulfonamide, they can form crystals in concentrated urine. So sulfonamide can form crystals that will cause blockage, and that can also look like a kidney stone, and you don't want that. So you want something that will flush it out. Then we have client education. So client education for UTI, pyelonephritis, glomerulonephritis, all the inflammatory stuff, they are going to look similar. You're going to look for similar stuff. So you avoid alcohol. Of course, everything you want to avoid alcohol. I haven't seen alcohol being a medication anywhere yet. Maybe I'm yet to see that as I grow older. So you take medications as prescribed. You're just talking to your patients normally, tell them to take the antibiotics as ordered, and then you also, the antibiotics are usually ordered for at least 10 to 14 days. Ideally, they try not to have patients stay on antibiotics more than 2 weeks. So sometimes they'll put it down for 7 days. Other times they'll put it down for 10 days, depending on the dosage. Other times they'll put it down for 14 days, but it shouldn't be more than that. So after the treatment of the medication, the patient has to be retested. So you repeat the urine culture after the treatment. So the patient was diagnosed as UTI, you give the medication for 10 days. The patient, you have to advise the patient, or you have to teach the patient, instruct the patient. All that means teaching. It means teaching action for the nurse to come back in 10 days for them to check the urine. Now, the causes of cystitis is you have allergens or irritants such as soap, spray, bubble bath, perfume, sanitary napkins, bladder distension, calculus, that's kidney stones, hormonal changes influencing alteration in vagina flora, indwelling urinary catheters, invasive urinary tract procedures like IUD insertions and all those things, loss of bactericidal properties of prostate secretions in the male, microorganisms, poor fitting vaginal diaphragms, sexual intercourse, synthetic underwears, and pantyhose, urinary spaces, people that are not able to urinate, the urine is staying up there. We have the use of spermicides in wet bathing suits. So for ladies that like using soaps and other things to clean down there, you can cause urinary tract infection. That's where the allergens or irritants come from. Now let's talk about urethritis. Do we have a question about cystitis or urinary tract infection before I move on? And remember, I said every client that has a problem with the urinary system, urinary tract infection, when you are assessing them or when you are treating them, try to educate them about fluid intake, increased fluid intake. And you never start the patient with antibiotics before you take the urine sample. Urine sample is first, just like in blood cultures, where you would draw the blood cultures before you start the patient on medication. So urinary tract is treated the same way. And when it also comes to the elderly population, you want to have an idea that they are prone to UTIs. And females have a higher risk of UTI than men because of the distance and the proximity of the urinary bladder or the urethra and the opening and the rectum as well. So women are usually prone. Any question? Any question?
No.
Okay. Urethritis. Now take notes. I have another one here. Urethritis and urethritis. My accent sometimes is hard. Trying to figure out the two of this. The only difference I can give you is that ureters, one has to do with the ureters and one has to do with the urethra. That's the difference. So let's look at urethritis, inflammation of the urethra. Inflammation of the urethra, and is commonly associated with STDs, sexually transmitted infections. And this may occur with cystitis. So if the patient already has a urinary tract infection, mixed with STD, it can cause inflammation of the urethra. In men, urethritis most often is caused by gonorrhea or chlamydia infection. So mostly in men, it is usually caused by gonorrhea or chlamydia infection. In women, urethritis most often is caused by feminine hygiene sprays, perfume toilet papers, or sanitary napkins, spermicidal jelly, UTI, or changes in the vaginal mucosal lining. Like I had said before, the irritants, when you keep putting soaps and sprays and bubbles, all those things down there, you can get your urethra inflamed. Now, assessment or signs and symptoms. There will be pain or burning on urination, urinary frequency and urgency, difficulty voiding, nocturia, that's in the night. Males may have clear to microplural discharge from the agents, from their urine. Yeah, females may have lower abdominal discomfort. So males may have clear microplural discharges from the agency. So they feel like they have to urinate, they go urinate and it's like pus. It looks like pus coming out in the urine as well. So that's the signs and symptoms. When you look at it, it does look similar to the first one we spoke about. It does look similar to your cystitis, inflammation of the urethra. So mostly, if you remember, I said urinary tract or urinary system, the symptoms that the diseases will present are all similar, apart from those that have to do with fluid restriction problems. So divide urinary system into two. We have some of them when it comes to dialysis patients, kidney failure, and all those things, peritoneal dialysis patients you are caring for, you want to help them restrict fluid. Patients with kidney rejection problems, and you want to help them be on a fluid schedule. But for patients with urethritis, inflammation of the urinary, the Bowman capsule, all the tubules that does the filtration. The last time we looked at the urine formation, all the tubules that does the filtration. Problems that has to do with the tubules and the urinary bladder, you want to encourage fluid. So their symptoms will be similar, painful urination, and all those things. So the same thing present with arthritis as well. So there'll be pain or burning on urination here. Pain, dysuria is same as pain in urinating. So you want to encourage fluid. So managing a patient with inflammation of the urethra, you encourage them to drink fluid as well. Prepare client. So mostly when you look at the signs and symptoms that the patient will present and the causes of it here, it will tell you what to intervene the patient for. So you tell the patient about the use of those sanitary stuff, the use of those sprays. You tell the ladies not to use those sprays around there because the vagina has its normal flora that keeps it protected and lubricated. So you educate the client towards that. So you need to have a general idea about the whole system, about the whole urinary system. And then that set of knowledge should be able to carry you safe to answer questions correct on the NCLEX. Now let's look at this one I put here. I said the ureters are fibromuscular tubules that propel urine from kidneys to the urinary bladder. And the urethra is a fibromuscular tubule that excretes urine from the bladder to the exterior. So that's the difference of it. That's the difference of it. So we have one that brings the urine to the urinary bladder. So the one that brings the urine to the urinary bladder is the ureters, and the urethra is the one that brings the urine from the urinary bladder out of the patient's body. And if we remember, it's in the picture. It's in the picture. So from here to here. Are we watching the picture?
Okay.
Are we seeing the picture?
Yeah.
Yes. So from here down is the urethra. It brings urine from the kidneys to the bladder. That's the urethra. The ureter. I'm sorry. So that's the ureter. Now the urethra, this is the urinary bladder. This is urine inside it. The urethra opens out to the exterior. This is where you now pee. So the urethra is the one that will open. So urethritis that we just talked about is when there's an inflammation in this tubule. When this tube here gets inflamed, you have pain on urination, burning on urination. And the causes is when you keep washing your stuff with the ladies, and the men will have microfluorine discharges and painful urination and all those things. Here, from here to here, when these tubes here are inflamed, that's where you have urethritis. Any question so far? I'm moving on. Okay. All right. So I'm going to pyelonephritis straight, but let me talk about it. So we have metronidazole or clotrimazole may be prescribed for treating Trichomonas infection. Nystatin, fluconazole. Fluconazole, they can give it to you to treat yeast infection. So because this one is all the way up there, sometimes they relate that one to yeast infection. So they can give you treatment for yeast infection. And fluconazole is antibacterial or something like that. Every day I forget the class it belongs. So they give you doxycycline or azithromycin too as well to treat chlamydia infections. So all those things fall under inflammation of the urethra. They cause the urethra to inflame. Now, pyelonephritis, an inflammation of the renal pelvis and the parenchyma commonly caused by bacterial invasion. Acute pyelonephritis often occurs after bacterial contamination of the urethra or following an invasive procedure of the urinary tract. So E. coli is the most common causative organism for pyelonephritis. If we remember the question we answered, it was glomerular nephritis, right? The question I did among the questions, it was glomerular nephritis. So this one is pyelonephritis. That has to do with the renal pelvis. If we look at where the glomerulus is located, is holding, is in between, is closer to the, like, it's in the middle of the renal pelvis. So when that one is inflamed, it's usually caused by bacteria, and that's the E. coli bacteria. So acute pyelonephritis, we have the acute and the chronic one, inflammation of the renal pelvis and the renal parenchyma cells. So acute one occurs as an infection, as a new infection, or it reoccurs as a relapse of a previous infection, and it can progress to bacteria or chronic pyelonephritis or pyelonephritis infection. So we have assessment. When you assess the patient, you see fever, chills, you see them having tachycardia and tachypnea. You see nausea, flank pain on the affected side, costovertebral angle tenderness. So you touch them, you have tenderness on their side, and there'll be cloudy, bloody, or foul-smelling urine. And white WBCs will also be elevated. So that's what you want to take notice of for patients with acute pyelonephritis. Now we have the chronic one. Is a slow. Anything that is chronic does not start one time, slow. So it's slowly caused by recurrent acute attacks. So you keep getting the pyelonephritis, and everything every day is acute. It moves to chronic. So this can cause the ureter to become fibrotic and narrowed by strictures. So this can cause urine retention as well. Then we have, it can lead to acute or chronic kidney disease. Now, the assessment is frequently diagnosed incidentally when a client is being evaluated for hypertension, initially to conserve sodium, and then poor urine concentrating ability. For pyuria, that's passing the urine, azotemia, and proteinuria. So when they run the patient's urine, they'll see all these things in the urine. They'll be passing the urine that you can visibly see. Then they run the urine culture. You see that there'll be protein in the urine to be elevated. That's what this one you assess and find. So mostly this assessment is going to come more of after doing the culture and sensitivity to find out the particular bacteria that is causing it. You're going to see all of this show up in the urine culture as well. We have the interventions is to monitor vital signs. Of course, you monitor everybody's vital signs, but any disease that has an inflammatory process in it, you want to monitor for fever as well. So it's not only this one. Again, like I said, you want to encourage fluid, and fluid will help reduce with fever. So all of them are presenting with inflammatory process, and you want to monitor for fluid. So monitor intake and output, and you want to ensure that the output is a minimum of 1,500 ml in 24 hours. So if you encouraging fluid up to 3 liters a day, you expect at least 1.5 liters to be out of the patient in 24 hours, and you monitor the patient's weight. So this is pyelonephritis. We have acute and chronic, and we have the assessment findings where you will see the client having elevated blood pressure. The client will not be able to conserve sodium. There will be pus in the urine, there will be protein in the urine. And when you monitor, you want to encourage, or when you intervene, you want to encourage fluid intake up to at least 3,000. So far for those inflammatory processes, you can see that the fluid encouragement is up to 3,000. But now when they are releasing the fluid, that's the output, you want to encourage at least, or you want to make sure that if you are able to give the patient fluid up to 3,000 ml a day, you expect them to return half of it. That is 1,500. Any question on acute or chronic pyelonephritis before I move on? Anybody has a question? Okay, glomerulonephritis, nephrotic syndrome, cyst formation and hypertrophy of the kidneys, which leads to cystic rupture, infection, formation of scar tissue, and damaged nephrons. There is no specific treatment to arrest the progress of the destructive cyst. The ultimate result of the disease is chronic kidney disease. The types, you have the infantile polycystic disease. So this is basically talking about types of glomerulonephritis. This is inflammation of the glomerulus. When you look at the glomerulus that I had explained, it contains the nephrons, and the nephrons are the functioning units of the kidneys. So if the nephrons are the functioning units of the kidney and they all get inflamed, everybody gets big, they get inflamed and they are all clamped up. They are not able to do its filtering work. So in adults, it does present with infantile polycystic disease, which is an inherited autosomal recessive trait that results in death of infant within few months after birth. And then adult polycystic disease is an autosomal type of infection. And this one manifests between the age of 30 and 40 years of age, and it can result in end-stage kidney disease. So most patients with glomerulonephritis, sometimes it comes from an external source. So basically from these two that we have read, it looks like you do have some form of genetically inherited background to be able to get to infantile polycystic disease and adult polycystic disease. But glomerulonephritis on its own is inflammation of the glomerulus and the structures inside of it. So assessment findings, patient will often be asymptomatic until the age of 30 to 40. So this has to do mostly with the adult polycystic disease, because the other one, death of the infant, is usually early. So it's hard to have them survive without a properly functioning kidneys. That's chronic. That's inheritance. We have flank lumbar abdominal pain that worsens with activities and is relieved when lying down. Fever and chills, recurrent UTIs, hematuria, blood in urine, protein and pus, calculi, that's kidney stones, palpable abdominal assessment, enlarged kidneys, increased abdominal girth. The interventions is for you to monitor gross hematuria, which indicates cyst rupture, and increase sodium and water intake because the sodium loss rather than retention occurs. So in glomerulonephritis, because the nephrons are all inflamed and diseased up, they are not able to excrete. Remember when I spoke about the urine formation, when the urine drops inside the bone marrow capsule, the renal or the nephrons are supposed to be able to filter them. The meshy tissue, the glomerular capillaries are supposed to be able to filter the urine out. So when these tissues are all inflamed inside, or when the nephrons, which is the functional unit of the kidney, is inflamed, then you are going to start having problem with excretion. You'll be retaining water, you'll not be able to release them as well. And you have blood in your urine because they are all diseased and they're struggling. Any question with that? Do we have any question?
No.
I'm moving to hydronephrosis. Are we sleeping? Hello?
No.
I'm here.
Okay. I'm moving to hydronephrosis. This is distension of the renal pelvis and calluses caused by an obstruction of normal urine flow. The urine becomes trapped proximal to the obstructed area. The cause include calculus, that's kidney stones, tumors, scar tissue, urethral obstructions, and hypertrophy of the prostate. So women, we don't have a prostate, but that's for men. Now, when you assess a patient with hydronephrosis, so hydronephrosis is when the renal pelvis is distended. So inside of you, your renal pelvis gets distended. And when it's distended, it's as a result that there's calluses, there's hardening somewhere that has caused obstruction of urine to flow out. So the urine is filtered, but in the renal pelvis, after the filtration and everything, it's not moving in so well. So it gets obstructed. So when you assess the patient, you see that the patient blood pressure will be high. The patient will have headache. The patient will tell you they have colicky or dull flank pain, and that radiates to the groin area. It radiates to the groin area. So mostly that's the complaint a patient will tell you. So I have this pain down in my lower abdomen. I don't know if it's my pelvis, but it does move to my groin area. Don't conclude that all groin pains are hernia. They are not hernia. So what will you intervene for in this patient? You want to monitor the patient's vital signs as usual. You want to monitor fluid and electrolyte imbalance, including hydration after obstruction is relieved. Monitor for diuresis, which can lead to fluid depletion, and then you monitor the patient's weight. Renal calculi, this is kidney stone. Let's talk about it. What is kidney stone? So let me enlarge this one. What is kidney stone? Renal calculi. Okay, so calculi are stones that can, they are stones that can form anywhere in the urinary tract. However, the most frequent site is the kidneys. So in the UTI, in the urinary tract or the urinary system, stones can form anywhere. Stones can form anywhere in the lines, all the tubules. They can accumulate a stone, something that can block. So mostly it's in the kidneys though. The problem resulting from calculi are several intermittent pain, obstruction, tissue trauma, secondary hemorrhage, and infections. These are possible causes that can cause the calculi formation. So the stone can be located through radiography. They can do X-ray of the kidneys, the ureters, and the bladder. They can do IV pylography, CT scanning too, and then ultrasound. All these are possible tests that they can do to confirm that there's a stone in your kidneys. So a stone analysis is done after passage to determine the type of stone and assist in determining treatment. So usually for patients who present with kidney stone, they are going to see it in the X-ray. So when they bring the X-ray picture and you see the X-ray screen, you see that the patient will have something inside the kidneys. I did have a picture of that. Let me see if I get that picture. I will show you. So you see that there's a stone and it can be located anywhere in the renal tubes. So let me see. Okay, can we see this?
Yes.
So this is how a kidney stone will form. So what this is an image of an X-ray. So when they do the X-ray, this is the pelvis. This is the human pelvis. But this is the renal system side. This is the kidney, right, left. So, or this is the right, the left and right. So this one is where the stone is at. So the X-ray have indicated the stone here. So this is the kidney stone that you have. So it goes to fit anywhere that the formation started. So let's say a blood vessel got bursted or you had a UTI and this one had a lot of dirty substances that were collected there and it got stuck there, or you had some kidney trauma, some injury that was not identified. Sometimes it's dietary as well, some kind of foods you are eating, then it keeps accumulating and then it gets bigger. So it causes a blockage here. And when it causes a blockage here, because the flow is not free or it's not freely moving in and out, the patient is going to have severe pain. So when they have severe pain and they come, such pain, you give the patient Tylenol, they tell you it's not helping. So it's an inflammatory, mostly anti-inflammatory medications help with that pain, like ibuprofen, Toradol, those ones will help. But you give that patient morphine, and trust me, they will tell you the pain is still there. I have personally taken care of patients who present that, and you keep giving them morphine and it's not helping. The moment you give them ibuprofen or Toradol, which is the IV form of anti-inflammatory medication, they tell you that this medication was the one that helped. But morphine doesn't help them with that kind of pain. So let's go back to our discussion. So that's kidney stone I just showed you. And apart from the CT scan, ultrasound, and other things they would do, sometimes they have to do urolithiasis and to use the formation of the urinary calculi, this form in the ureter. So sometimes they have to do nephrolithiasis to also try to relieve all those things. They have to do surgical intervention to remove those things. But most often they try to have the patient hydrate. They have the patient hydrate and pass out the stone. It's really hard to deal with those things. They want you to drink a lot of fluid to help you pass out the stone. And when you pass out the stone, they have you bring the stone for analysis. They tell you, when you ever pee it out, you see the patient pee it out. So you tell the patient, you give them a container to send it home. They pee out the stone, they put it inside. It's painful. It's painful to be able to pee out a urine stone, especially in the men. But sometimes they will pee it and it come out. So they leave it in a container and they bring it back to the hospital. Sometimes you look at it as big as this thing. And it's just pathetic, but it's sad. Now, what causes it? Some people it's family history. Other people is dietary, like I said, vitamin D, protein, oxalate, prunes, or alkali. Those things cause urine stone. Obstruction and urinary stasis. So if you are not able to empty all your urine, dehydration, use of diuretics, which can cause volume depletion, UTIs and prolonged urinary catheter depletion. Then we have mobilization, hypercalcemia, hyperthyroidism, elevated uric acid levels, such as in gout. So patients with gout are at risk for urine infection. They're at risk for renal calculi. Assessment finding, you have a renal colic, which originates in the lumbar region and radiates around the right and down to the testicle in men and to the bladder in women. So this is, it starts from the lumbar region. So they will describe the pain is just here and it moved down to this way to my bladder. And then there will be urethral colic, which radiates towards the genital and thighs. So you just, like I pointed, the pain will just start from your back and it start moving down to your private areas. We have sharp, severe pain with sudden onset. So you were fine yesterday, but this morning you wake up and it's just like something hits your back and that never stopped. You just look at something went to drop inside and that pain never stopped. So there will be signs of UTI, urinary frequency with altering at retention, low-grade fever, high numbers of red blood cells, white blood cells, and bacteria noted in urinalysis report. There will be gross hematuria. So in the urine analysis, you see blood positive. So we have interventions, is vital signs, temperature, monitor intake and output, assess for fever, chills, infection, and you continue monitoring your patients. And you also teach the patient dietary measures. They are all part of your intervention. So for clients with renal calculi, strain all urine for the presence of stone and send the stones to the laboratory. So like I said, some stones are big, other stones may be very tiny. So you can do a 24-hour urine collection to strain the urine. So remember, it is within your job description to strain patients' urine. If the patient problem is urinary stones or urinary calculi, you can strain the urine for stones. So it is not something you should not do. So take note when NCLEX present to it. It is not awkward, it's not out of sight. Straining urine is part of what an RN should be doing. Now, cystoscopy. It may be done for stones in the bladder or lower ureter. So this is an intervention. They put a scope to view the stone in the bladder. Then we have the extracorporeal shock wave lithotripsy. So these are interventions for patients with urinary stone. So we have the non-invasive mechanical procedure that they use for breaking up stones that are located in the kidney or upper ureters so that they can pass spontaneously or be removed by other methods. So this is a non-invasive procedure, this extracorporeal shock wave lithotripsy. So they put a shock wave into your kidneys and then they have it break the stones and you pass it out. That's why you most importantly would have to strain that urine. So you do it, put the patient on 24-hour urine collection and you strain the urine. And if you find the stones, you put them in a clean container and you send them to the lab. Then instruct the client to increase fluid intake to flush out the stones and fragments. A stent may be placed to facilitate passing out fragments as well. So these are interventions you would do for a patient with kidney stones. Percutaneous lithotripsy. So lithotripsy is just like a process of trying to crush the stone that is inside the kidney. So an invasive procedure. So this one, extracorporeal, is not an invasive procedure, but this one here, percutaneous lithotripsy, is an invasive procedure in which a guide is inserted under fluoroscopy near the area of the stone. An ultrasonic wave is aimed at. So they use an ultrasound waves. So they put an ultrasound, they are monitoring it, and then they use the tube, they insert it straight down to your renal tubes, and then they try to crush the stone. So they try to break the stones with that. If we remember how they declot, they take out the clot, pulmonary embolism. When there's pulmonary embolism, how they insert the tube from your femoral vein up to your heart to be able to suck out that clot. Or how they do endoscopy, they insert the tube through your mouth down to your stomach to be able to view structures. So lithotripsy and cytoscopy and percutaneous lithotripsy and extracorporeal are all procedures that try to crush out the stone to just bring it out and you be comfortable. So uretero-lithotomy. This one, tomy means they are cutting, they are removing part of the stone in the ureter. That's what it means. So all of these are surgical interventions and you will have a part to play. So you have to pre-operatively prepare the patient. Now let's look at kidney tumors. So kidney tumors may be benign or malignant, bilateral or unilateral, one or both kidneys. So the common size for metastasis of so if we ever remember about cancers or tumors, we have malignant and metastatic, benign, malignant or benign. So the malignant ones are those that move faster. Benign are just kind of mild. They are not aggressive, but malignant are aggressive. So when you assess a patient who has that, the exact cause of kidney tumors are carcinoma, which is unknown. I will call it cancer cells, and it's unknown. They don't know that one. So the patient will have dull flank pain, palpable renal mass, painless gross hematuria. So if you remember all the symptoms I keep mentioning about these renal problems, you see that they are all in the same category. You just want to talk about blood and urine when there's inflammation and all those things, protein, the labs will be off. So it's a straightforward system that gives you system-specific signs and symptoms that patients present. So have a broad knowledge of that system specific. Now let's look at nutritional therapy for calculi. Nutritional therapy for calculi. So depending on the type of the calculi the patient has, the diet is modified to decrease foods that are high in substances that is the cause of the calculi. So if the patient eats too much prunes, and when they analyze the kidney stone, when they bring the stone and they analyze it, then you want to advise the patient towards that to be able to minimize that kind of food. So prunes are high. We have high sardines, herrings, mussels. mucels, some of the food stuff, I tell you, I don't even know them. I don't know them by face myself, especially those that I haven't eaten before. It's hard to tell. So we have salmon, crab, and all those things. So you want to tell the patient to minimize them. If they analyze the stone and it's as a result of too much of food, prune-contained foods, then you want to minimize the calcium. So these are foods that are high in calcium. You want to tell the patient to minimize it if the stone was analyzed to be more of a calcium component. So that's why they do the kidney stone analysis. They analyze the oxalate. So if these are foods that are high in oxalate, so if the kidney stone was in relation to that, you would advise this. So uric acid is a waste product from prune in foods. So foods that have prunes in them, uric acid is a protein, is a byproduct of that. If you have gout, because they are at risk for kidney stones, they encourage them to reduce prunes. They are more at risk for gout because of the uric acid component in it. Now let's look at epididymitis. Any questions so far? We are all done. Inflammation of the epididymis. That occurs as a result of UTI, STI, prostatitis. So this is mostly in men because they have the penis, they have the long one, they have the epididymis. The epididymis, epididymis, they have it. So mostly this one is inflammation of the false skin around the penis. So the ineffective organism travel upward through the urethra and ejaculates that and along the vas deferens to the epididymis. So mostly for the men that have not been circumcised, they will usually have such a problem because the false skin comes out to cover it. So when you look at the penis, the false skin will protrude and cover the whole thing. So when there's an inflammation, it moves down the urethra and it causes infection. So when you assess the patient will report scrotal and groin pain. There'll be swelling in the scrotum, pus and bacteria and urine, fever, chills, abscess development. So there may be abscess. Intervention is, again, epididymitis. Remember the mitis, inflammation. You want to encourage fluid, encourage bed rest with the scrotum elevated. So remember, for a patient with epididymitis, you want to have them elevate their scrotum to prevent traction on the spermatic cord. And then this will facilitate drainage and relieve pain. Prostatitis, any question? This is inflammation of the prostate gland. Any question with epididymitis so far? You see, they're all presenting the same interventions, fluid management, because the inflammatory process. So have a general knowledge. I keep repeating that. Have a general knowledge about the kidney or about the renal system. So far as the problem is the system that is inflamed and there's something that is causing fever, you want to hydrate, you want to relieve pain as well. So if it's bacteria involving, you want to think antibiotic administration. Then we have the bacteria type occurs as a result of the organism that is reaching the prostate via the urethra, bladder, bloodstream, or lymphatic channel. The A bacteria type usually occur following a viral illness or a decrease in sexual activity. So this is prostatitis, inflammation of the prostate gland. Mostly it's men who have prostate glands as well. So we have the bacteria type, the one that is caused by bacteria, and it will cause the bacteria, it will cause the organism, organism, yeah. So this one is because the organism travels from the prostate through the urethra. The urethra is the one that helps open to release urine from the urinary bladder. So from the urethra, it travels up, not down, travel up into the bloodstream. So it goes up through the urethra and then into the kidneys, and then it goes into the patient's bloodstream. So instead of having it come down, the bacteria is rather going up the urinary system. So when you assess the A bacteria type is usually as a result of viral illness. So you had common cold, which is a viral infection, and then 10 days later you present with this. So let's look at assessment findings. We have bacterial posthitis. Clients become acutely ill in the bacteria one. Acutely ill. You have fever, chills, frequent urination as well. Remember, dysuria, which is painful urination, is constant. Perineal and lower back pain, same complaint. So urinary problems present with back and lower abdominal pains. Take notes when you are assessing patients or when they are asking you the questions. So patient give you that complaint, you follow up. Do you have burning or urination? Do you have any fever, any vaginal discharges? You follow up. So patient presents you with lower back pain and lower abdominal pain. Don't assume it's GYN. It may not be reproductive system. It may be urinary tract or urinary system that you need to look out for. So take note of this. White blood cells elevation, you know it will be constant with any inflammatory process as well. The A bacteria type, the one that is not caused bacteria, most common from is the most common form of chronic prostatitis. It's no bacteria that is causing it, so you cannot relate it to bacteria. The patient will have back pain as well, blood and urine frequency. They are just repeating themselves. They're repeating the signs and symptoms. For those that did the GI system and the respiratory system, you can see that all these symptoms keep repeating for one system. So that's what I want you to pick for the NCLEX. So when you are tackling the systems on the NCLEX, note that when they're asking you the questions, if you understand the general management of one system, all the diseases that will come under them, the signs and symptoms are obvious to have them. Now, benign prostate hypertrophy. Now, but before I move to that one, look at the interventions for prostatitis. Intervention, encourage fluid as well. You see how that thing is a big deal. So mostly they can drive you to this. They want to know you encourage fluid at least 3,000 cc or 3 liters per day, and you encourage half of it as output. You want to monitor that the patient is able to release half of it as output. You don't want everything coming out. That means there's a problem as well. Benign prostate hypertrophy. That is our last topic for tonight. So benign prostate hypertrophy, I think most of us would have been familiar with this. It's a slow enlargement of the prostate gland with hypertrophy and hyperplasia of normal tissues. So this is mostly another problem with men, So when you think women, you want to be worried about UTIs because we get them more often. But when you think of this inflammatory process that has to do with the prostate, epididymitis, stuff that men have in extra of their urinary system that we don't have, because ours is just a short tube from the bladder straight to the urethra and then straight out. We pee it out. That's why we also easily get infection. But men have the long one, and they have the epididymitis, the false skin around it that can accumulate bacteria, especially if the person is not circumcised. So they also have the benign prostate or the prostate problems, the prostate gland disorders. So benign prostate hypertrophy, when we talk about hypertrophy, something that has become hardened, So normal tissues become inflamed, they become a little bigger and harder, become tougher. So I would want to relate it like when you cut beef and you put the beef on fire, it starts becoming hard. Or when you put when you put an egg in hot water that is boiling, you see that the outer skin layer starts becoming harder. But when you crack it fresh, it's watery all over. But when it warms up, or the more you drop it in hot water, it starts becoming hard. So this is how the prostate gland hypertrophy and they become hardened and thick. So there's enlargement that compresses the urethra. So because the prostate gland is right underneath the it's around the scrotum, so it's just a gland around that area. So it puts pressure on the urethra. It puts pressure on the urethra that help release the urine. So it's in between it's around the testicle. So we know where the scrotum is. So it is there and it enlarges. So when it enlarges, it puts pressure on the urethra that release the urine. So this results in partial or complete obstruction, and it usually occurs in men that are older than 50 years. This is why they encourage men to do self-assessment. Like women do breast examination every time. They encourage men to do assessment. They go to the hospital for prostate gland assessment all the time. And they're supposed to also do scrotal self-examination. So we have assessment is to diminish and force of urine strain, early sign of BPH. So you see that there will be diminished urine and they are forced urine in the urinary system. They're forced to urinate. So you go to the bathroom and you are trying to pee and you're doing, it's not coming. And it's very hard to force urine like you can go and you are bearing down like you want to poop. But when it comes to urine, you really cannot bear. You just have the edge and the muscle needs to be informed to open. But here's the case, there's an enlargement, there's a distraction somewhere that has hardened it. So you are the mind or the brain, all the nerves are working, trying to open, trying to do its job, but there is an obstruction, so it's not able to come out. So they have urine urgency and frequency. So the patients start running to the bathroom every few minutes, and they're not even able to pee enough. They're not able to pee everything. So in the night too, it happens mostly at night as well. They will urinate all night. So inability to start or hesitancy or to continue urinary stream. So they are not able to urinate much. So you are feeling the urge to urinate, you run to the bathroom and you are still not able to urinate. That sucks. So you encourage fluid intake, 2,000 to 3,000 a day, unless it is contraindicated. If the patient has UTIs, has BPH, and has congestive heart failure, has edema of the ankles, you want to also question the fluid intake. But if the patient don't have none of that, and the patient is just presenting with only the BPH, you encourage fluid intake to be able to eliminate bladder trauma. And this occurs following a blunt or penetrating injury to the lower abdomen. So penetrating injury to the lower abdomen. We have the blunt trauma, which causes compression of the abdominal wall and bladder. Penetrating wound occur as a result of stabbing, gunshot wound, or other obstructive piercing the abdominal wall. A fractured pelvis that causes bone fragment to puncture the bladder is a common cause of bladder trauma. So I don't know if you have ever seen a patient who had an accident and has like a hip fracture around the hips that has caused like several organs down there to be affected. That's a trauma. It can affect your urinary bladder. Another thing I have seen is a patient with cancer of sacral wound. The patient has a sacral wound that has moved so deep into the pelvis area, it has affected a lot of organs there, and now the person cannot even urinate. Most of them, they will end up putting them on urostomy, just like the colostomy. They have to divert the urinary system. It has to be coming through a bag as well. So the interventions is assessment. There will be anuria. There will be hematuria, pain below the lower level, the level of the umbilicus. So level of the umbilicus, we know where the umbilicus is, or the pain will radiate to your shoulders, nausea and vomiting as well. Intervention, again, monitor vital signs, monitor for bleeding, signs of shock. Remember, we are talking about trauma here. So where there's trauma, you are worried for bleeding. So you maintain bed rest. If blood is seen at the meatus, that's the men, you avoid urinary catheterization. So the moment you see the patient bleeding from the penis, you don't want to push a urinary catheter through that. You don't want to push anything through that because you'll be causing more damage. They can do an ultrasound to know what's going on. There are other screening procedures they can do, but you don't want to push a catheter. So prepare the client for insertion of suprapubic catheter to aid in urinary drainage if possible. So suprapubic catheter is the one I just spoke about. Sometimes they put in patients on urostomy. So they put a suprapubic, they put the suprapubic catheter on the abdomen, on the lower portion of the abdomen, and they divert the urine through that. So they put a catheter through there, and then they have the urine drain in a bag. So most of them, they end up putting them on urostomy. That's just a similar procedure. So you also prepare the client for surgical repair of laceration if indicated. So because it's a trauma, you want to prepare them for laceration. The last topic, which I did not talk about, is cancer. But these are topics that you would need to know for your NCLEX when it comes to renal system. So if you didn't get anything at all, just make sure you write the names of the disease conditions down. Bladder trauma, you write BPH, you write prostatitis, you write epididymitis, then you write all of them. You write all of them down. Then every day your mind tells you, do I have information about this particular disease? And when I am assessing, what do I look out for? Remember, renal problems, hydration is key. Renal diseases, except for other or some of them that you have to restrict fluid. So if you notice any renal condition presented to you on the exam that has a tendency of fluid buildup, then you don't want to think hydration, you want to think fluid restriction. But besides that, all the inflammatory process of renal system, of the disease conditions, they encourage fluid. Hemodialysis, no, you don't encourage fluid. And when a patient is on hemodialysis and the blood pressure is low, you put them on reverse Trendelenburg and you give them oxygen and you call for help. That's the management. We also have the peritoneal dialysis. We have the continuous one that you continue with it, and the intermittent peritoneal dialysis as well. Those are the disease conditions. And I also spoke about what's the name? I also spoke about kidney transplant. Patients who get kidney transplants, they have to stay on immunosuppressive medications for life. Immunosuppression medications for life. And we have acute rejection and chronic rejection. We have the super acute or hyperacute rejection as well, which starts within 2 days after the insertion of the new kidney. Now, the donor has to be compatible with the kidney recipients. And we have state policies. When you sign to donate your kidney whilst you are alive, when you die, your family will not stop. Your family will not stop them from taking your kidney. They will definitely take your kidney out because you had signed. What about the one who gives the kidney? Are they on medication as well? Well, the one that gives the kidney, they only can put them on medication after the donation. They treat them. They get some form of treatment as well until their bodies adjust to their new one kidney function. But until that, they usually wouldn't have you on medication. They just take you through a preparation process to have you donate. It's a surgical procedure they have to do to you to get your kidney out, and they put you on medications. So after you donate the kidney, then you'll be on medication as well. Any question?
No. It's a lot, patient.
It's a lot what to learn?
Yes, it's a lot. Oh, God.
So group them. That's why I take the pain to go over them one after the other, just to mention it to you. Sometimes what your mind hear when you sit on the exams, it makes so much sense. It rings a bell in your ears. you will not be able to you don't need to know every single thing to go. That's why I'm telling you, you group them. You know the symptoms that are specific for renal system. And you don't go talking about, what do I say? You don't go talking about, let me look for a symptom that is from another system. You don't go talking about, the patient has a kidney failure and the patient presents to you and say, I have pain in my chest. The pain moved from my stomach, this side, on the left side, and it goes to my chest. And I keep burping and burping. That wouldn't tell you to assess for kidney problem. That wouldn't tell you to assess for kidney problem. So remember, the kidney is at a lower part, but remember the kidney has a connection with the heart. So a patient having kidney problem can come back to present with heart problems. So just look for the general signs and symptoms that are specific. I keep talking about urine frequency, urine urgency, burning or urination, especially when it comes to inflammatory process, fever. You see all these things. And when you're managing the patient, you encourage fluids most often. So try to group them in orders. I know it's a lot, but I take the pain to mention all the disease conditions one after the other, just for you to take notice of them. So if you are not able to get everything right, but try to repeat the video. Sometimes when you sit on the exams, things you cannot remember, it rings a bell in your mind. When you hear the sound of somebody's voice, it rings a bell in your mind. So these videos are handy. At your own convenience, you can always put them and you are busy doing your stuff. Okay?
Okay.
Yeah. I know it's a lot, but
It's a lot.
I wish I could help.
Yeah. You're helping.
Yeah, I wish I could do the studying for you, but
Yeah, I wish you were there when I'm taking the test. I wish you could be there.
it's unfortunate I cannot learn for you, but I'm just giving you all the tricks that have worked, and it's going to work if you go it that way. Group them, write them all down, group them. When you are answering the questions, come back to look for the symptoms, and that will give you a repeated learning opportunity, and then it sticks in your mind. And you also go back and listen to these videos at your convenience. Sometimes you're at work, you're on break. Just put it on your phone. That's why I made it flexible, handy. You just put it on your phone, put it in your ears, put your earphones, and you are sitting like you are sleeping and you are listening to it. So self-discipline is the key to this. Self-discipline. You have to learn to discipline yourself. If not, it's going to be hard, because life has we have come to a point that you are matured, you have a family, you have kids, you have to worry about parents, you have to worry about kids, school fees, bills, and other stuff. But if you have to get this done, it's also another responsibility. So you have to put it in your budget, you group yourself. There are times you will just have to sit quietly and study, but there are times you cannot get that time. If you worked yesterday, you're working today, you come home, you are really tired. I would be lying on my bed and I have the book open and I make sure I do like 30 minutes study. I study something for 30 minutes. And I'm not just studying. One thing I want to tell you is that don't just be a steady person. Don't just study because you want to study. Make sure that when you open the book to study, even if it's 20 minutes you are spending on that book, if it's 20 minutes, make sure the material you are learning, make sure you understand that material. I don't want to cheat myself. I don't want to waste my time. So you sit on the study material, you open the book, and then you are on phone, you are texting the phone every few minutes. No, sometimes mute your phone or turn it off. Tell yourself within 20 minutes, I'm going to study and I'm not going to be distracted. 20 minutes when you spend on a material is a quality time for you to understand that material one time and you don't come back to it. So you have to self-discipline yourself. If you don't self-discipline, it's going to be hard. And you don't want to keep doing this up and down, back and forth. It frustrates you for no reason. It's not that you are not knowledgeable, but the exam is not for people who are knowledgeable. It's for people who understand the tricks of it, who understand the information they want you to tell the patient, who understand the information you can critically analyze and figure out the right thing to do at this moment. That's what the exam is tricking you for. I know a lot of people who have given up, but some of them, if you look at them, they have like exam cramp. They are just trying to go over the book because I'm opening papers, and they're not picking out anything. It's just like this, our spiritual life. You have somebody who is always sitting on the Bible every day, reading and reading. I'm using the Bible because that's what I know. I'm a Christian. I have a co-worker. She will come to work and she's just sitting on the Bible. You have a patient dying. She don't show no attention. She's meditating. At the end of the day, the action you are even putting doesn't even show that you know what you're doing. You see? So don't waste your time on books. When you pick the book to read, make sure that 1 hour you are spending is a meaningful 1 hour. People have done it. And